Hi everyone, thanks so much for being here today. My name is Shin, and I'm joined by my colleagues Yena Kim, Yeon Sun-jung, and Hang Lim from the Division of Gospel Hospital at Goshin University, College of Medicine in Busan, South Korea. It is because of God's extra help that I'm able to present these topics. Today's lecture is part of a series on disease organ donation and transplantation, and we are going to be doing a deep dive into a topic that is absolutely foundational to that field, and honestly, one of the most important and sometimes misunderstood concept in all of the medicine, brain death. We've got about 20 minutes together, so let's make every minute count. By that time we are done, I want you to walk out of here feeling confident about what brain death really is, how we diagnose it, and what some of the bigger ethical and legal conversation look like around it. Let's get started. So here's what we are going to cover, your roadmap for the next 20 minutes. First, we are going to nail down the definition of brain death, also called death by neurologic criteria or DNC, based on the most current guideline. Then we go dig into the pathophysiology, basically what's actually happening inside the brain that makes this condition irreversible. From there, we will walk through the 2023 AAN consensus criteria step by step, what the prerequisite you need to check off before you even start the clinical evaluation. We will talk about the amnia test in detail, including when you need to about it. Then we will look at the ancestry test, which ones are the acceptable, and importantly, which ones are not, including why EEG was actually removed from the guideline. And finally, we will touch on some of the ethical, legal, and family communication challenges, because this is not just a clinical checklist. There's a very human dimension here what we cannot ignore. All right, let's start with some history, because brain death did not just appear overnight. It's a concept that evolved over the decades. Back in the 1968, and this is really the starting point, the Harvard ad hoc committee defined irreversible coma. That was a landmark moment. Then in 1981, the U.S. enacted the Uniform Determination of Death Act, the UDDA, which defined death as the irreversible cessation of all brain function. That's still the legal started in the United States today. Fast forward to the 2010, when the AAN published its adult brain death guideline. Then the 2020 brought the World Brain Death Project, an international effort to harmonize criteria across the countries. And most recently in the 2023, we got the big unified guideline from the AAN, the AAP, CNS, and SCM covered both adult and the pediatric patient under one framework for the first time. So what's the 2023 definition? It is the complete and irreversible cessation of all function of the entire brain, including the brainstem in a patient with catastrophic brain death, brain injury, and in the absence of any condition that could confound the clinical assessment. That's a lot of words, but the key phrase is complete, irreversible, entire brain, including the brainstem. Keep that in mind as we go. Now, let's talk about what's actually happening biologically. Why is brain death irreversible? What causes it in the first place? The most common precipitating causes include traumatic brain injury, anoxic or hypoxic ischemic injury from the cardiac death, massive stroke, or intracranial hemorrhage, fulminant hepatic failure, and severe CNS infection like meningitis or encephalitis. Here the core mechanism. Whatever the initial insult, it causes intracranial pressure ICP to rise. When ICP climbs, cerebral perfusion pressure, that's the MAP minus ICP, started to fall. Once the CPP dropped below about 50 millimeter of mercury, you start getting global ischemia. As ICP continues to rise, you get the herniation, either transtentorial or tonsillar, which compresses the brainstem and progressively knock out the brainstem reflexes one by one. The endpoint is cerebral circulatory arrest, ICP, actually exceeds the mean arterial pressure, and there's essentially no brain flow to brain anymore. You can confirm this on the angiography. Without blood flow, neurons begin to autolyze within the minutes, and the damage, unlike so many things we deal with in medicine, is completely and totally irreversible. One important distinction, the US standards under the UDDA requires whole brain cessation, cortex and brain death. The UK and some other countries use brainstem death standards, which is slightly different. And critically, log-in syndrome, vegetative stage, one of those are the brain deaths, not even close. Brain deaths account for about 2% of US hospital deaths, so it's not common, but when it happens, getting it right is absolutely critical. Okay, before we even touch a patient for the clinical exam, we have to satisfy a set of prerequisites. All of them, not most, all of them. First, establish the etiology. You need to know why this patient is in this state. There must be known the diagnosis compatible with the brain death, and neuroimaging, CT or MRI, must be consistent with catastrophic brain injury. If you cannot explain what happened, you cannot proceed. Second, no drug confounders. There is huge, no sedatives, no analgesics, no neuromuscular blocking agent. The guideline says to wait at least 5 half-lives. And for an NMB agent, specifically, use a train of 4 testing to confirm that they're gone. Third, normothermia. Core temperature must be at or about 36 degrees Celsius. Hypothermia, even mild hypothermia, can suppress neurological function and give you a completely first pictures. First, hemodynamically stability. Systolic blood pressure need to be at or about 90 millimeter of mercury and MAP at or above 60. You need to educate the cerebral perfusion pressure to make the assessment valid. Fifth, no metabolic confounders, normal electrolytes, glucose, acid-base state. Specifically, sodium should be 160 or less, no thyroid crisis, no Addisonian crisis, nothing that could independently suppress brain function. And six, an adequate observation period, typically at least 24 hours from the event onset, For anoxic injuries in pediatric patients, that observation window is even longer. Think of a prerequisite as your the safety net. If you skip them and make a long call, the consequences are the catastrophe. Alright, prerequisite cleared. Now we move to the clinical exam. There are three mandatory components, and every single one must be confirmed absent. If even one is uncertain, you are not done. Component 1, coma. The patient must have GCS of 3, that's the floor. No proposal for the motor response to pain, no spontaneous eye opening. You test with noxious stimulation, supraoptical ridges, nail bed, sternal pressure, and here's a key teaching point. Spinal flex is like the Lazarus sign, where the arm may move, can persist in brain death. Do not interpret those as evidence of the brain function. Their spinal cord reflexes are completely different. Component 2, absent brainstem reflexes. This is a specific checklist. Pupil must be fixed, no response to bright light, and mild dilated to full dilated. No oculocephalic reflex. That's the Dorsey eye test. No ocular vestibular reflex. That's ice water caloric testing. 50 to 60 millimeters in each ear. No corneal reflex bilaterally. No gag reflex, no cuff reflex with trachea stimulation. Every single one has to be gone. Component 3, apnea. This deserves its own slide, and it gets one. The core idea is that even with significant CO2 stimulus, the patient make a zero respiratory effort. We will walk through the protocol on the next slide. The apnea test is often called the cornerstone of brain death determination, so let's walk through it carefully. Step 1, pre-oxygenation. Put the patient on 100% FiO2 for at least 10 minutes. You want SpO2 at or about 95% before you disconnect anything. Step 2, get the baseline ABG. Confirm your PaCO2 is between 35 and 45 millimeter of mercury. pH should be 7.35 to 7.45. You need a normal starting point, so the CO2 rise is meaningful. Step 3, disconnect the ventilator and deliver passive oxygen 6 liters per minute, either through the endotracheal tube or a T-piece. Keep monitoring continuously. Step 4, observe for 8 to 10 minutes. Watch the chest, watch the abdomen. You are looking for any respiratory movement, any at all. If there is even a hint of a brain, the test is not positive. Step 5, draw another ABG. You need the PaCO2 greater than the 60 mm of mercury and a rise at least 20 mm of mercury from the baseline. The 2023 update also added pH must be 7.3 or below. Both criteria need to be met. Step 6, if there was no respiratory effort and the ABG criteria are met, the apnea test is positive, supporting a brain death determination. Now, when do you abort? Abort immediately if the SBP dropped below 100 mm mercury, SpO2 fall below 85%. There's hemodynamically significant arrhythmia, or the patient is progressively desaturationing. Patient safety always comes first. If you abort, you will need the ancillary test, which is our next topic. Here's the deal with the ancillary test. They are not required for routine brain death determination. You only need them when the clinical exam or amnesia test cannot be completed, maybe because of severe facial trauma or because the amnesia test had to be aborted. So, what's acceptable? The gold standard is a 4-vessel catheter cerebral angiography. It directly shows you that there's no intracranial blood flow about the C1, highly definitive. Next, radionuclear cerebral perfusion scintigraphy, SPECT scanning with technetium 1919M HMPAO. This is the most commonly used ancillary test in practice. Important caveat: it has not been validated in kids under 2 months of age. Intracranial Doppler is also acceptable, but adult on. It looks for reverse benevolent or absent flow pattern. Do not use it in the pediatric patient. CT angiography is widely available and can be used, but the 2023 guideline notes that the data is still limited. Use it with caution. Now, what's now acceptable? This is really important. EE is out, completely removed from the 2023 guidelines. Why? Because EEG only assesses cortical activity. It tells you nothing about the brainstem function. And the brainstem requires whole brain sensation, auditory evoked potentials, and somatosensory evoked potentials are also unacceptable for the same reason. Incompleted brainstem coverage and the standard MRI and MR angiography do not have sufficient validation for this purpose. If someone in your institution is still using EEG as an ancillary test for brain death, this needs to be changed. Let's talk about what can go wrong because the first positive brain death determination has profound, irreversible consequences. This is one situation where you absolutely cannot afford a mistake. Several conditions can mimic brain death. Drug intoxication is the most common. Barbiturate, benzodiazepines, opioid, ketamine, baclofen. One of these can suppress neurological function to the point where it looks like a brain death. Hypothermia, even just being below 36 degrees, can abolish all brain reflexes. Several metabolic derangement, profound hypoglycemia, severe hypernatremia about 160, adrenal crisis. Neuromuscular conditions like Guillain-Barré can't produce the login appearance. And even short-acting sedatives like propofol or dexamethasone can accumulate, especially in patients who have been on them for a long time. And the common critical purpose performed in the exam before the toxicology has been cleared. Not waiting long enough, especially in the anoxic injury, interpreting spinal flexes as brain activity, not achieving an adequate CO2 rise during the amnesia test, using EEG as an ancillary test, which again is not unacceptable, and not having a second independent examiner, which most institutional protocol requires. The bottom line, be thorough, be patient, and don't cut corners. The 2026 guideline includes several entirely new sections that were not in prior guideline. Let's hit the key ones. Pediatric patients. This is the first time we have had unified the adult and the pediatric guideline under one document. Age-specific considerations are important. The scanning is validated in the kids 2 months and older, but the TCD is not validated in the children at all. Neonates and infants require longer observation periods, but the 3-component exam, coma, absent brainstem, lymphoprexis, amnesia, applies to kids too. Pregnant patient. Yes, brain death can be declared in a pregnant patient. That's sometimes a source of confusion or discomfort. After declaration, somatic support may be continued to support fetal viability. But this is ethically complex territory. You need the multidisciplinary team, the ethic consultation, and the careful attention to gestational age, family wishes, and the legal contact. Primary posterior fossa injury. This is another new section. The clinical exam remains the priority, but the imaging is required to rule out the confounders, and there's often higher reliance on the ancillary blood flow studies. And on the consent and the time of death, there's no legal requirement to obtain family consent before brain death evaluation, but obtaining family agreement is considered best practice. And importantly, the legal time of death is the moment of brain death determination, not the time the ventilator is withdrawn. Document this clearly. Let me give you a quick overview of the ethical and legal landscape, because this is an area that's actively evolving, especially here in the US. The UDDA from the 1981 required irreversible cessation of all brain functions, and that's the rigorous binding standard across the country. But there's been the ongoing debate about whether it needs to be updated to align with the 2023 clinical guideline. The AAN has been running an active advocacy campaign to encourage state-by-state adoption of new guidelines. Nevada was the first state to formally adopt it as the accepted medical standard. 2 states, New Jersey and New York, allowed religious exemption, meaning families with a specific religious belief can object to the brain death determination. That's a unique legal landscape. Globally, there is a significant variability. The UK used the brainstem death standards, not whole brain. The whole brain death project in 2020 tried to harmonize the international criteria, but cultural and religious acceptance varies widely. In Japan and some Middle Eastern countries, brain death as a legal standard has historically faced significant resistance. On the publicly acceptable side, a recent 2025 study found that about 82.5% of nursing students accept the medical definition of brain death, and just over half prioritize quality of life over life preservation in the VD cases. That tells us there's still educational work to be done. I want to spend a moment on something that does not always get enough attention in clinical training, the human side of this. Families often struggle to accept the brain death because the patient does not look dead. They are the warm, they may have color in their skin, their heart is beating. There's a profound cognitive dissonance there. Repeated empathy, clear communication is essential. And the language matters. You should say, your loved one has died, not we are considering withdrawal or things do not look good. Ambiguous language leads to first hope and more suffering. Give families time. Respect the cultural and religious rituals. Palliative care and social work should be involved. On organ donation, the dead donor's rules means we can only procure the organs after legal death is confirmed. Brain death patients are actually the highest quality donors because there's no warm ischemia. The OPO, organ procurement organization, must be contacted per protocol. And here's a real important practice the principle. Separate the brain death conversation from the organ donation conversation. Different team, different timing. Families should never feel like the goal of declaring brain death is to get their loved one's organ. That conflation destroys the trust. Involve the ethics committee when the cases are complex or disrupted. And remember, public trust in the brain death determination process is essential if we get it right, consistently, and compassionately. That trust holds. Let's quick walk through the step-by-step checklist for clinician. Step 1. Establish the etiology. CT or MRI showing catastrophic brain injury with a documented compatible diagnosis. Step 2. Confirm all prerequisites: temperature, hemodynamics, lab, medication, document every single one. Step 3. First clinical exam. Coma plus absent brainstem reflexes. Document each reflex individually in the medical record. Step 4. Amnia test. Follow the protocol. Document pre and post ABG values and document whatever it was completed or aborted and why. Step 5. Second independent examiner, an attending physician with the specialty required by your institution, performs the full exam independently. Step 6. Ancillary testing, if needed. Document the indication, the specific test used, and the interpretation. Step 7. Declare the time of death. This is a real time. It goes into the medical record immediately. Step 8. Notify the OPO and communicate it compassionately with the family. Your institution will have a specific protocol and documentation form. Know it, use it, and don't deviate from it. Alright, let's land this plane. 6 takeaways to walk away with. 1. Brain death or DNC is the complete irreversible cessation of all brain function, including brain death, brainstem. That's the 2020 AAN definition. 2. There are 3 mandatory components: coma, absent brainstem reflexes, and amnia. All 3 must be confirmed. No shortcut. 3. Prerequisites are the absolutely critical. Rule out every potential confounders: drug, hypothermia, metabolic derangement, before you even start the exam. 4. Easy is no longer acceptable as an ancillary test. It was removed in 2023 because it only assesses the cortex, not the brainstem. Use perfusion imaging or TCD in adults instead. 5. Family communication is not optional. It's a clinical skill. Be clear, be compassionate, and keep the brain death conversation separate from the organ donation conversation. 6. Global variability is real and going. The US is working toward state-by-state adoption of the 2023 guideline, but different countries use different standards. Know the legal context in which you practice. And that's a wrap up. Thank you so much for your attention and engagement today. Brain death is one of those areas where the precision matters enormously, both for the patient and the family in front of you, and for the broader system of trust that makes organ transplantation possible. I hope this lecture gave you a solid current foundation to work from. If you are looking to go deeper, I'd highly recommend reading the full 2023 AN, AAP, CNS, SCM consensus guideline, Career and the Radiology 2023. It's comprehensive, well written, and the most authoritative reference available right now. Thank you. Take good care of your patient. Thank you so much.